Hi, I hope everybody has their lunch and is ready to talk about the subspecialty meetings that we had this year. So I'm Kathi Kinnett. I'm a nurse practitioner. I work with the care team with PPMD. As you may or may not know, PPMD focuses on several organ systems throughout the year and has several subspecialty meetings that to delve more deeply into those areas regarding care and management of those systems. And in addition, we have a summit that includes all of the care providers, many care providers from all of the certified Duchenne care centers, and we have a summary of each of those meetings. So the first presenter is Linda Cripe. She's a physician at Nationwide Children's and a cardiologist at Nationwide Children's. Some of you may know her. She is incredibly involved in organizing the cardiac meetings that we have had, and she's going to talk about what we talked about this year. Linda?
Thank you, Kathi, and it's really an honor to have the opportunity to talk with you guys today. And I forgot this. Oh, here's the slide clicker. And the first meeting I would like to talk to you about, as Kathi mentioned, was a cardiac workshop that was held this past May in Baltimore, Maryland. I think it's important to appreciate the fact that when you support PPMD, not only are you supporting the efforts that you're seeing here at this meeting, but you're supporting all of these side meetings that are going on that are really instrumental in orchestrating change within the community, and so I thank you for having the opportunity to help lead this meeting this year. So the meeting objective, our overarching meeting objective, was to initiate a discussion regarding the creation of a clinical trials consortium, and that we have designated to be called a DRG, a dystrophinopathy research group that will facilitate the performance of clinical trials. So the meeting was attended by 32 cardiologists or physicians, other physicians, pulmonologists, neurologists. We really wanted to target the meeting to people who were deeply engaged in the community. On previous occasions, we've had larger meetings, but on this meeting, we really wanted to invite people who were going to be able to help us create that DRG that I had talked about. We had 18 industry representatives as well as patient representatives and support staff from PPMD. In the meeting, we had 6 sessions, and we focused on a variety of things, and then I'll go through in a little bit more detail. The first one being current treatments and future needs, industry perspectives on the heart and clinical trials, 3, the impact of gene therapy on the heart, 4, cardiac transplantation and ventricular assist device, also referred to as VAD use in Duchenne muscular dystrophy, and cardiac care in late-stage disease, and the final session was on where do we go from here. So in the first session, where we talked about current treatments and future needs, we discussed pathology, and there has been a push recently to try to more closely examine hearts that have either been explanted for transplantation, or when we put in ventricular assist devices, we actually have the ability to sample the myocardium and then look at those tissue samples. There's clearly a need for more analysis of cardiac pathology, because what we learned was that there is significant fibrofatty replacement, which is really important in the disease process. So it tells us, it helps inform us about what we're seeing on our imaging, and it helps establish those correlations that are really important to serve as biomarkers in future clinical trials. We also had extensive discussions about the use of cardiac MRI and disease evaluation, and current treatment algorithms were reviewed with consensus that new therapies, as they arise, will need to be added thoughtfully. And PPMD has helped us to build a robust registry through an organization called Action that's run out of Cincinnati Children's Hospital. It's a network of pediatric cardiac centers in this country that are committed to the treating pediatric heart failure and transplantation. And we've been very effective at connecting up to that organization, which is going to be instrumental into instituting cardiac change. This registry is allowing us to learn a great deal about medication usage, as well as allowing us to build harmonization of protocols that will allow us to treat all patients more effectively and efficiently. The second session was an industry perspective on the heart and clinical trials. We were actually honored to have significant representation from industry, and I've just included the names here of those companies that were present, but I think that they were very informative to the clinicians, and it's really nice to be in a room with them so that we can establish close partnerships that will allow us to institute change in the future. We actually asked all the industry partners to complete a pre-conference survey, and one of the questions that we asked them that I thought was relevant to sharing with you today was that from your perspective, what are the biggest barriers to cardiac trials or collection of cardiac data? And there were some barriers, and one of those were issues related to cardiac MRI, and I think the issues are that, cardiac MRI isn't readily available at all institutions or all centers, and not necessarily all centers in Europe or in other countries, and so that does pose a barrier to collecting data in clinical trials. There was also a paucity of natural history data, or there was a lot of variability in the natural history data that allows us to not know that if we're seeing a change in a clinical trial, what that implies or what that means. And then there's just, they thought that there was a lack of generalized consensus within the field of pediatric cardiology that would allow them to effectively run their clinical trials. And so it allowed us to have a lot of vigorous discussion with our industry partners into how we can surmount and tackle some of those barriers, which is invaluable to helping us lead change. The third topic, which I think will be a theme throughout the rest of the meeting, and a really important theme that I think we really need to spend a lot of time talking about, is the impact of gene therapy on the heart. And I think it's going to be very clear that the heart can be impacted in in a lot of complex ways, and that there is absolutely no question that we are going to need to monitor the cardiac disease of gene therapy patients, not only in the short term, but the long term who have undergone gene therapy. Not only the young children, but there may be significant risks for the older boys from gene therapy, especially those with depressed cardiac function. And so there was a lot of really important, vigorous, heated discussion about how we're going to do this. Clearly, universal protocols need to be constructed, and industry needs to be encouraged to include cardiac endpoints in their trials so that we know what the impact of their drugs are on the heart when these drugs get approved. We also spent some time talking about cardiac transplantation and ventricular assist device use in Duchenne. There are obviously a lot of ethical implications associated with transplantation. Both treatment directions, transplantation and VAD use, come with a host of positives as well as negatives. And I think it's important to know that this meeting helped spark the organization of another meeting, which will be held in September at Stanford University with a group of transplant cardiologists to explore these issues in greater depth. And having been in the Duchenne space now for almost 2 decades, I can tell you that this has been a long time coming. When we started these discussions 20 years ago, absolutely no one wanted to hear or think about transplanting a patient with Duchenne muscular dystrophy, and now we're having very fluid and open discussions, and patients with Duchenne are being offered cardiac transplantation. And I think that's because of the work of organizations like this and the efforts that all of you contribute. We then talked about cardiac care and late-stage disease, the desperate need to utilize databases to better understand treatment outcomes, and ACTION does offer a platform that we can use to collect this data. There was clearly a need for higher integrity data to understand the complex natural history of the disease. And like I mentioned earlier, we're going to need autopsy specimens, as grisly as that sounds, but we need pathology specimens to help make clinical correlations and help allow us to understand the disease process better. And there's some newer drugs. One of those is SGLT2 TI inhibitors. And do these drugs have a place in Duchenne? So we need to be able to translate what we've learned in adult and pediatric heart failure communities into this patient population and know if those therapies will be effective and safe. So where do we go from here? ACTION, I think, is the way. I am so pleased and so proud of the efforts of ACTION. Chet Villa, who was unable to make this meeting at Cincinnati Children's, is leading the efforts in this regard. It's a network of pediatric cardiac centers across the country with leaders in the field of pediatric heart failure and transplantation. And we've come together and have frequent discussions and meetings, and ACTION was a huge part of this meeting. And the efforts with regards to their plug into Duchenne have been as a result of the support of PPMD and their kind generosity in supporting the importance of this network. John Zaslow at Vanderbilt University runs a clinical consortium, and he was present at the meeting, and there is going to be a close partnership between his organization as well as ACTION. Harmonization of care protocols needs to occur, and harmonization means that if you get seen at, for example, Cincinnati Children's, that the exact same care will be delivered at Nationwide Children's, and the exact same care will be delivered in California and Florida and Boston, that you don't have to go doctor shopping for cardiovascular care. And getting us all on the same page is strangely not as easy as it sounds, but we are working in that direction. So we need to build a clinical care and clinical trial group, which we have referred to as the GRG. And so I'm cycling back to the whole objective of this meeting was to come together, discuss these issues, and get together a group of people that, in a funded environment, that we can collect this data and move these questions and find solutions. So this DRG thing, what's that going to look like? Well, data will be held by PPMD, we think, in a complex academic environment, currently with intellectual property concerns. It needs to be in a neutral location. The world of academic medicine these days is complex, and navigating each institutional's requirements is not as simple as it was. We're going to start slow and easy, and we need to get some early wins. No huge bites to start with, such as gene therapy. One of the questions, gene therapy is going to be a really complex question for us to answer, but we all want to come together to demonstrate proof of concept on maybe a simpler question. We don't also want to duplicate any efforts that are also underway, and we do want all the groups to work in parallel. The DRG should be overarching group with ACTION, and the work at Vanderbilt should come together under one umbrella. It could be a subset of the clinical trial centers that are already present, and we'll have to look at the accessibility and the enthusiasm for each of those centers to participate in this. And platform trials are important as well, and over the next several days you'll hear about platform trials and the importance in clinical care. So, big takeaways from 2 days in Baltimore. It is critically important that we have a collaboration between centers. I think everybody will agree on that. We need to expand clinical trial databases. We need to obtain and include more functional data endpoints. We need to develop a data-informed, inclusive approach to ethical decision-making in advanced cardiac therapies. And I'd like to thank you. I'd like to thank you for your support of PPMD, and I would like to thank PPMD again, and I keep saying it over and over again, but we could not be doing this without this organization. And so I will turn it over to our my next colleague.
Thank you, Linda. Linda's takeaway is always the heart's a muscle too, but you can't live without it, so it's really important to keep that healthy. Leanne Ward is a physician and endocrinologist at the University of Ottawa, and she's been a passionate supporter of endocrine care in Duchenne. Most patients are started on steroids very young and take them consistently, and that leads to bone weakness and ultimately fractures and other issues. So bone health has been really important, as well as other endocrine care. So Leanne, do you want to talk about the endocrine meeting?
Well, thank you, Kathi, and it's so wonderful to address this amazing audience. I appreciate the opportunity to give you an update on recent endocrine and bone meetings in Duchenne. We're extraordinarily grateful for PPMD for having the foresight to bring those of us who are working in endocrine and bone health together. We'd long been admiring each other's papers and work from a distance, and everyone came together recently in order to really start to effectively move the dial in a direction that will be helpful and also with a speed that we aren't able to do individually. When we think about endocrine and bone issues in Duchenne, we're certainly mindful of the fact that the landscape is changing drastically with new therapies and with steroid types of drugs that have different profiles like vamorolone. So as we go forward in this space, we're mindful of the fact that when we tackle these complications, we're doing so on a background of an ever-changing landscape. We came together in Rome in April 2023 to discuss endocrine and bone issues in Duchenne, and we discussed that the issues we wanted to focus on were fractures due to osteoporosis, growth attenuation and arrest, pubertal delay, rapid and excessive weight gain, adrenal suppression causing insufficiency and adrenal crisis, as well as intimacy, friendships, fertility, and sexuality, all of which ties into puberty. And as you can see, we have glucocorticoids at the fulcrum of these issues. We know that the dystrophinopathy itself, even independent of steroids, causes osteoporosis and also short stature. And then classic glucocorticoids augment the risk of bone fragility. They amplify the short stature, and they cause delayed puberty, adrenal insufficiency, and a tendency to gain weight. We discussed in Rome that certainly glucocorticoids are with us for the foreseeable future. And so we're not in a situation where we can back off thinking about these complications. But if anything, we need to intensify, given that high-dose steroids are used, for example, even in gene therapy, albeit over a shorter period of time at very high doses. So we appreciate that glucocorticoids have significant benefits to muscle strength and cardiorespiratory health. And what we want to do is to mitigate, to attenuate the adverse effect of steroids on endocrine and bone health so that patients can benefit maximally from the glucocorticoids where their underlying disease is concerned. We discussed that the endocrine and bone issues in Duchenne are serious, that with long bone fractures or even just with low bone density, you can have a phenomenon called fat embolism syndrome or adrenal crises following a bone fracture that leads to a crisis that needs to be identified and treated in a timely manner. We know that fractures due to osteoporosis can cause permanent premature loss of ambulation, which is devastating, and weight gain, and both of those cause diminished physical function. And then there's the psychosocial burden of appearing younger than you are because of pubertal delay, the premature loss of ambulation because of fractures and excess weight, as I said, and the burden of additional medical visits and treatment. So when we met in Rome, we had the singular idea to ensure that we were meeting the minimum standards of care and thinking about the global barriers for what we need to overcome in order to do that. But we were also focused on how we could move the dial by intensifying the standard of care. For example, taking bone health care from institution at the time of first fracture to starting before fractures occur in order to prevent those osteoporotic fractures, as just an example. So in Rome, we talked about new developments in drug therapies targeting the dystrophinopathy and how that might influence the endocrine and bone landscape. We talked about the impact of vamorolone, a dissociative steroid, on muscle strength, growth, puberty, weight gain, adrenal function, and skeletal health. We started to think about how we would identify patients in order to initiate bone protection prior to first fractures, and we developed something called the POP score, which I'll tell you about in a minute. We talked about the implications of newborn screening to endocrine and bone issues, and the importance of growth, puberty, friendships, intimacy, and gender identity to patients and families. And then we also talked about new avenues in order to foster collaboration in these areas. This is just one example of one of the topics we discussed in a little bit of detail. So we came up with some ideas that are preliminary for how we can take an individual with Duchenne at a young age and develop a score that will allow us to understand their risk of a fracture in the near future, and that in turn would guide us as to the time that we needed to start talking to the family about starting bone protection before first fractures. And we joked that in Italy that worked well in different languages, the POP DMD score. So at the end of the meeting in Rome, which was incredibly dynamic and really brought it into the room a lot of enthusiasm, we decided we needed first and foremost to have a manuscript that discussed all of the issues that were raised at the meeting, and that manuscript is under favorable review by the Journal of Neuromuscular Diseases, that we needed to strike working groups for each of these 5 endocrine and bone health issues in order to move the dial post-Rome and not let all the ideas just fall at the time of that meeting. And we decided that we needed to come together and work collaboratively for research initiatives targeting endo and bone health in this changing landscape. So we went on to develop newly the Optimized DMD Consortium, or Learning Health Network, which stands for Optimizing the Management of Endocrine and Bone Health in Duchenne. And the vision for this consortium is for it to take those of us who've been working independently, bring us together, and in a international and collaborative way, propelled by PPMD, move the dial on the management of these important issues in endocrine and bone health. After the Rome meeting, we gathered as a sort of Jedi council, if you will, with Pat, Jared Wong from the UK, David Weber from the US, who's here, and myself, and we started to plan, okay, how are we going to harness this enthusiasm and all these ideas that came out of Rome so that we can keep moving forward? And so we decided that we would do some background work, but that we needed to meet again and take advantage of the synergism that comes from face-to-face meetings. So we decided to gather 6 months later in Ottawa, which is the capital of Canada. So Toronto is not the capital of Canada. It's the home of the beaver tail, which is this lovely little pastry that's after our national animal. It's the home to Justin Trudeau, who Stephen Colbert says likens to the Prince of Tangled, and the home to many lovely outdoor types of activities. And this is our parliament because we are the capital of Canada. So we came together in Ottawa with the idea to form this consortium under the governance of a steering committee that I just mentioned, and then to have these 5 working groups tackling all the key areas in endocrine and bone, with patient advocacy at the heart of all that we do. And so with the families and the patient advocate representatives as the fulcrum of the initiative, we are focused on improving clinical care, improving the education about that care, making sure that we're at all times thinking about advocating for the patient now and in the future, and seeing research as the engine of change. So after the Ottawa meeting, these are some of the initiatives that came out of it. We populated our Optimized DMD Consortium working groups with interested healthcare professionals from the United States, from Canada, from Latin America, and the UK. So each working group has co-chairs and members, and there's about 35 individuals from these different areas that span these different working groups. We developed terms of reference for the overall Optimized DMD vision and governance strategy. We created a brand, a logo, and started to build a website, and I'll talk about that in a minute. And we stood up a secretariat in Ottawa to facilitate the Optimized DMD proceedings. We came up with the first logo on the left, Optimized DMD, and that was endorsed. And then when we went to build the website, we wondered if it was a little bit too much like Lego kind of primary colors, so we've come up with a second logo. And so when you pass me in this meeting, if you like logo 1, just give me 1 finger, and if you like logo 2, just give me 2 fingers. And I'll take that back to the steering committee. So what have we done since we met in Ottawa? Well, one of the things we wanted to do very urgently, in fact, was to have a position statement out of Optimized DMD that would give healthcare professionals and also have a companion article for families to tackle adrenal insufficiency. Now that we have vamorolone, we need to consider the ways in which adrenal insufficiency needs to be managed differently with this dissociative steroid on board. And we are updating the enduring guidance document called PJ Nikolov Steroid Stress Dosing Protocol. And Dr. David Weber, working with other individuals as part of the consortium, is leading the adrenal insufficiency initiatives. The group has written an article that will be submitted for peer review as well, tackling adrenal insufficiency, and we think it's so important that we need an international readership as quickly as possible. And then each of the 5 working groups have initiated manuscripts, which we call the tier manuscripts, and we have received permission to submit all 5 of these manuscripts to the Journal of Neuromuscular Diseases as a special issue. So for each working group, there will be one paper that tackles the current standard of care, the new developments in each of the working groups that have taken place since the standards of care were published in 2018, so the ways in which care has changed that we think should be implemented now. And Tier 3 is the future directions that we see for endocrine and bone health care as we go forward in order to optimize the landscape. Other Optimized DMD initiatives include the creation of an international Optimized DMD ambassador and partnership program. So we have a vision that we have these key members of the Optimized DMD consortium, but that we have an outreach program, that we reach out to colleagues around the world and understand where they're at in meeting their endocrine and bone healthcare goals and meeting them on their terms. So we'll be going, some of us, to Rome in the fall of 2024 to work with the Italians on their own Optimized DMD programming. And then some of us within the consortium are working on research grants to tackle development of fracture prediction models to identify best candidates for early anticipatory osteoporosis prevention, the study of therapeutic strategies to prevent weight gain and bone fragility, and understanding the understudied landscape of friendships, intimacy, gender identity, fertility, and sexuality. The Optimized DMD Consortium is incredibly grateful to PPMD, who serves as a guiding light and critical enabler of our work. They brought us together, and we're partnering with them hand in hand as we go forward, and we could not be more thankful for that partnership. I think sometimes it must feel like PPMD for them, that they're pushing us uphill, or maybe they feel like they're pulling us along, but either way, we're getting there, and we appreciate their efforts. Certainly, I think that research is the engine of change, but the wheels are PPMD, and they help us keep moving forward. And with that, I'd just like to finish by drawing attention to this beautiful artwork by Ricky Tegens that was shared with me in October of 2023 by his mother. And this artwork by Ricky has memorialized and emblemized for me what the Optimized DMD Consortium's vision is, and that is to go forward with sensitivity to the space, with granularity and attention to detail, and with vision. And with that, I thank you for your support and your engagement in our activities. Thank you.
Thank you, Leanne. That was an excellent summary of that meeting, and it was very complicated and continues to be ongoing, and we hope to continue all the great work that we're doing with you, so thank you for your partnership. Emma Ciafaloni is a neurologist at Rochester, and she's going to talk about the summit. So the summit is a meeting that we hold once a year that where we involve at least 4 clinical providers from each of the certified Duchenne care centers. They all come together, they're in one room, and they have big meetings and big discussions. So Emma is going to summarize what we talked about at this year's meeting.
Thank you for spending your lunch with us. So the PPMD Summit, what a wonderful meeting that is. As you know by now, you and your family has learned that it takes a village to take care of this disease. And that village is comprised not only of doctors all kind of doctors, the bone doctors, the heart doctors, the muscle doctors, and on and on. But there are a lot of other team professionals, physical therapists, social workers, nurse practitioners, coordinating nurses, psychologists, genetic counselors. And for that kind of team members, there aren't really a lot of meetings where you can all meet together to exchange ideas and how to do things better, basically. So the summit, to me, is extremely unique in that sense because it's an opportunity for the professional teams that work in Duchenne Becker muscular dystrophy to get together and brainstorm about opportunities as well as challenges. And also remember the multidisciplinary clinic that we have in the countries are not all created equal. So depending where you are, you implement the best standard of care and multidisciplinary team care, adjusting to your own environment, geography, and other systems where you're working with. So the summit is really a great opportunity to different teams and different models to really exchange ideas and really to discover that maybe, you can do things different and better. The ultimate goal is really to serve our patients' community better. So that takes very many different forms, but I think that getting together and listen how other teams are doing it, it's a huge part of to serve our community better. The two themes this year at the summit, which I think everybody loves, the big one was what keeps us up at night as teams, and the other team, what can we hope for? So where can we land in that balance between hope and what keeps us up at night, and how can we all be more comfortable accepting what we don't know yet, and that the model we have now is certainly not perfect, but how can we be comfortable with that and keep striving to do better? So one of the big session and theme for the summit this year was really combination therapy, right? Combination therapy, the therapeutic landscape has so rapidly changed in the past several years that now we have this concept of combination therapy, which is quite novel in a way. So there are more options, and with more options come more questions and imperfect answers, because sometimes we have seen that new drugs approval, the pace of that is faster than really having all the precise answer and the data that apply not just to a small subgroup that was studied in the trial, but to everyone that we see in clinic. So those team, the clinical team, they don't just see the population that was studied in a specific trial. They have to be comfortable discussing a specific drug with everyone. And so those answers are imperfect, and that's where we really brainstorm about how do we go about with those important conversations. And combination therapy is here to stay. It is only going to grow. Another big concept that is very important, that FDA approval of medication is not equal access to medication, at least in our system and environment. And I think that also opened up very important and nuanced conversation in the clinic. And I think that setting expectation and clarify those expectations of approval versus access is very, very important, and be honest about it. And also we talk a lot about how clinical care and research clinical trial assets overlap so much, and sometimes the decision of how to access certain treatments really goes between clinical care and research access, and waiting versus not waiting for something better. Basically, the big shift in the model is that the multidisciplinary approach, you see all those bubbles of the different care team members. That model plus corticosteroids, that harmonization of care that we have struggled for so many years to achieve, really has dramatically improved survival for Duchenne Becker muscular dystrophy, but also quality of life. So it's unequivocal that the model works very well. And in that model, until really a few years ago, that was the model and corticosteroids. Now, there is a all new approach of combination therapy, because now we can finally target dystrophin restoration. So in the orange panel, dystrophin restoration comes in different flavors, as we will see, and it can be used in combination with downstream pathology targeting medication that really target inflammation, muscle fibrosis, and regeneration of the muscle, which is not just corticosteroids. And really, so dystrophin restoration plus downstream mechanism of action for different drugs, and the timing. When is the timing where there is the window of opportunity to have the most impact on that reversible process of muscle necrosis, inflammation, regeneration, or irreversible process? And so, as you know, right now there are several dystrophin restoration medication, exon skipping, and gene transfer, many more in development, next generation exon skipping and PPMO, and many different mini dystrophin undergoing development in clinical trials. And from downstream, we now have more options for corticosteroids beside prednisone and deflazacort. Vamorolone, of course, has just been approved. And then we have the first completely different mechanism of action, Givinostat, also approved, and others really in phase 3 clinical trials. So an all array of options that open up also questions. So for corticosteroids, it's unequivocally universally accepted that corticosteroids is standard of care. There is overwhelming evidence for short-term and long-term effectiveness. We now have several options. And so what we discussed a lot at the summit is really how to choose which one is best, when to start, what age. And, you know, the field has moved to younger and younger. I think that most of us will feel comfortable 4, maybe 3, but now we might have newborn screening. We don't really know the 0 to 4, 0 to 3. And then when to switch, right? If something better come along, is it for me? Should I switch, and why? And how does the conversation really should occur of why and when switching? The other big discussion and brainstorm was between exon skipping and gene therapy. As we know, when we talk about dystrophin restoration, we always talk about not a full-length normal dystrophin. With exon skipping is much closer to the full-length dystrophin. With gene transfer, we have mini construct, mini and micro dystrophin. But as you know, exon skipping is only for about 30% of patients. Gene therapy is for a larger portion, but it's not for 100%. There are exclusion criteria. But what if you're a candidate for both, for an exon skipping drug and for gene transfer? And in terms of gene transfer, is it better to wait for something better, next generation? Do you wait to enter a clinical trials, or do you access what's available now, how to best choose a trial, and also it's already out there. We have seen it with other diseases, with spinal muscular atrophy, for example. Well, can I get both? Is it dangerous? Is it rational to get both? And if so, again, it goes back to that access, right? Well, if we do think that maybe it's an okay thing to do, are they going to actually let us do it? Could we use both dystrophin restoration strategies? And we talked about approval versus access quite a bit. And I think that you need to find a team that obviously had the know-how, the infrastructure, and the support to fight for access to drugs. That's unequivocally very important, but also to have an expectation that there are certain things that are simply beyond the control of your clinic team, and that your team cannot always win. But it's a process, and obviously you're part of that fighting and the process, and as working together toward really changing the policies, right? And that we do all together, the families, the patients, the providers, and PPMD and the foundation, and it's a moving target. And then really the equity in resources, it really takes even a bigger village to deliver these very complex therapies, and we need to be very well aware of what we need to advocate for, to do it timely, to do it well, and to do it safely. Health equity also came up, not obviously at the level of clinical care and access to best possible treatment for all, but also improving diversity when it comes to clinical research and clinical trials, because there are unequivocally barriers for certain socio-demographic group to access the clinical trials and research. And this is not just in Duchenne Becker muscular dystrophy, this is in general in research. And in rare diseases become even more compelling though, because we really want to include everyone to have an opportunity to participate in trials if they're good candidates and if they want to. But how do we do better in our system to taking those barriers away? And we talked a lot about ethical issues, research regulatory issues, and many others where we can all really contribute and do better. The diagnostic delay, as you know, it's a fact in Duchenne and Becker muscular dystrophy, and unfortunately it's a very persistent reality that is never been acceptable, but certainly no longer acceptable now that we have so many more options for intervention. Thanks to the incredible support and efforts of PPMD and many others, newborn screening is becoming a reality. A few states are actually starting screening, Ohio, New York, and Minnesota. And with that comes many important opportunities to data collection and research, and really learn more about the nuances of, for example, your genetic mutation and how can we prognosticate. Are you going to be a Duchenne or a Becker or in between? An incredible amount of learning that can occur that, but also the challenges that we need to acknowledge and work on, and really the still not good agreement in terms of standard of care for the 0 to 3. So now we're going to have newborns, very young infants. How do we do best by them in terms of care? And there was quite a bit of ideas there. And I think that whenever we meet in these meetings as team, and the summit is phenomenal. My team, every time we come back from summit, they are so reinvigorated. You probably have heard there is a lot of burnout in healthcare. We need more space, we need more support, we need a lot of things. And these are the type of meetings that we come back and we want to work harder. So it's a fantastic meeting. But we also come back to talk to our patients. And so what is it that you can do? Obviously, it's incredibly important. You need to find a clinic team that you trust. And, medicine is complicated. million. But this is a marathon. Duchenne Becker muscular dystrophy is a marathon, it's not a sprint. You have to find a team that you trust, and that you trust especially when the answers are not perfect. And the honesty to say, we need more data, we don't know, I'm telling you the best, but there is uncertainty. So that becomes even more important, right? If it was black and white, then it gets easier. For us, it's a good problem to have because definitely things are getting absolutely in a hopeful direction, but there is uncertainty. So find a team that you trust, that you can be comfortable with some uncertainty. Consider always participating in research if you can. Learn what the research is about and what you can do. And advocate with us, advocate with PPMD, advocate with your clinical team. Going back to access, and we can all advocate together, and then educate around you. You know, not everyone has access or the possibility to participate in meeting like this one or the summit, or to go to a clinic that is, you know, prominent and among the best in the country. But you can always spread, you know, if you are fortunate enough to have access to all this, educate others around you. And I think that's all I have about the summit. And I think that the idea that also we're always thinking is to bring a body. So, you know, we always think about sometimes subspecialty, especially in the adult subspecialty. They don't really know all that much about our rare diseases. So the idea is bring them to one of these meetings, bring a body, you know, because, okay, the expert that you see at this meeting, they're already on board, but we need to bring more average and people to really get excited about our diseases, especially now that there is so much more that we can do. So bring a body to Summit and to PPMD, and that's something that we can all advocate for. So I think that's all I have. Thank you for being here, and I hope you enjoyed the rest of the meeting. So thank you.
Thank you, Emma. I think one of the things that I'm most proud of around the summit meeting is that, first of all, everybody's in the same room. And second of all, it's so interesting to me how all of these meetings feed on each other. They don't, nothing happens in isolation. So do you guys have any thoughts about that?
I mean, I think that it's a critical component to moving the field forward. I think that it's these behind-the-scenes efforts that occur in a conference room in a hotel on a rainy spring day where you have really active discussion amongst the thought leaders in the field. I mean, it just doesn't happen in this day and age. You know, we're all very busy, we're all moving too fast, and you really have to stop people and put them in a room together and force them to have these discussions. So I think, especially after COVID, I think that these meetings are more critical than ever to foster forward change.
Yeah, I would agree with that. It always amazes me how far we get when we come together in person versus on Zoom. Zoom, of course, has been an incredible enabler in many ways to keep touch with people throughout the year, and there's certain ways in which that's helpful, but to get together, the dialogue is just different, and I think we feed off each other so much more dynamically when we are in person, so we appreciate the summit. And also, certainly, for me as an endocrinologist, osteologist, everything that I'm doing and thinking about has to be anchored in the treatment of the underlying condition. So to be able to attend the summits and see where the field is going in terms of targeting the muscle health and also just the psychosocial aspects of Duchenne and the way that engages with treatment of the underlying condition and dealing with side effects is very empowering. So I very much appreciate the summit for that reason as well.
I think the unique opportunity is also that we as neurologists, neuromuscular, we're kind of the home. And yeah, we need to be fairly comfortable with things that really endocrinology is a big one, and we had a session with the neurologist and the endocrine expert, like about delayed puberty and weight gain and other things that really, as neurologists, we learn from our colleagues. We advocate to say, you really need to find it, but we're not really the experts. So there is always learning. The other thing is we always come back from summit with, okay, we need to change this. We can do this better. And I think that multidisciplinary care is very easy to read a paper about it and say, oh yeah, you need to do multidisciplinary care, and this is the 25 people you need, and blah, blah, blah. But in the real world, actually implemented that is always a moving target. We can always do better. It's not once and done, oh, I got multidisciplinary clinic, I got all I need. No. It's imperfect, frequently because of the system we work in. And so we always come back with new ideas of trying something different. And I think that is hugely important.
I think the other thing, the other advantage of all these meetings is the ability to put everybody in the same room, to include FDA, NIH, and the monitoring organizations, as well as pharma, and to make all of these organizations, in addition to the clinical perspective, aware of how important all of these issues and body systems are in the development of clinical trials and policy. So,
yeah, no, I would agree with that 100%. I think the partnership between clinicians and industry has to occur for effective clinical trials. And I think sometimes if industry designs their trials in isolation, then critical elements are missed. For example, maybe missing surveillance of bone health, or surveillance of cardiovascular disease, or surveillance of pulmonary complications. And so I think to have that intimate collaboration between the teams is really critical, and that can only happen in person, or it happens best in person, right?
we have mics around the room. If you're at that mic, you'll need to wave at me because you'll be standing in the light. But I would love to have questions. I detest a silent room.
You know, while people are thinking of questions and maybe coming up to the podium, I think that, to me, I think it can't be overemphasized, the role that you all play in making these things happen. I mean, I realize that sometimes it seems like you're on an island, but you're not. And it's only when we come together and hold hands together do we institute change. And you say, well, what can I do? Well, you can support the organization. You can, you know, the dollars raised do make a difference. You know, these meetings have to have venues and they have to have conference rooms. You know, the participants are not paid to participate. They come, you know, out of their passion for making change. But so I think it is an intimate partnership that does involve all of you to help make this happen. And I think I'm, you know, trying to oversell it a little bit, but the change doesn't happen. And Kathy's been on this journey for a long time, and all of you have as well. And change occurs slowly. You know, I think everybody wants change to happen overnight, but it does occur slowly, and we have to chip away at it. And sometimes you think, well, you know, they had this meeting, and I don't see anything different. Well, 5 years from now, you will see something different.
Mindy?
I guess I forgot how tall I am. I want to know where we are with transitioning to adult care, especially now that we've got some treatments out there that adult specialists, who we're seeing as adults may not be as up to speed on. How are we going to go about getting prescribed these new therapies when we're maybe seeing an adult neurologist that we've never seen before, that is seeing patients with other different kinds of neuromuscular disorders. I'm in the middle of all this right now, and it's sloppy. It's been really tough, this transition. I've got some of his care here, some of his care there. He's very medically fragile at the time. It's like he's right when he needs better coordination of care.
Yeah,
it's fallen apart.
Yeah, unfortunately, I couldn't agree with you more. I mean, I think, you know, that is an area, and we actually just spent, interestingly, there was a pre-conference meeting of professionals, and we were discussing some of those issues. And there was no there's no question that everybody agrees that that is a huge problem. And changing that culture will occur slowly. And once again, though, I need to emphasize the fact that you are part of that partnership as much as you don't want to be and you shouldn't be. I mean, you really shouldn't be. But in many instances, if you live in a city or in a location where you don't have good providers, you have to help educate and push those providers to become educated. It is impossible for everybody to get on a plane and go to centers of excellence. But you can do a lot by pushing or changing. You know, I always make the analogy, if you're buying a car and you go into a car dealer and the car dealer tells you that, you know, the car is too expensive and they're trying to sell you something that you know isn't right, you don't hesitate to maybe stomp your feet and walk out of there. And I think that you should do the same with care providers. If you know that they are not telling you what you think is correct, use your gut. You know, you're probably right, and seek somebody else. And in an environment where you don't have expertise, you just want to find a kind, compassionate soul who's willing to make phone calls.
Thanks, and I do recommend to all the parents, take it as an old timer. You know, you have to stay on top of everything throughout your son's life, whether they're peds or adults. But I just want to kind of underline that if newborn screening comes on board and we have many, many older patients, that, you know, this idea that they can stay in their pediatric settings just isn't practical anymore. Thankfully, we have many, many patients now.
Well, every center is different, too. Like, our center will allow you to stay past 18. Some centers kick you out at age 18.
Hi, do you have a question?
So I would like to know, how good is the evidence for the long-term cardiovascular and respiratory benefit for steroids, and how did they arrive at that conclusion?
Emma, you want to? Can you repeat?
So the corticosteroids data that has been accumulated over decades now, we know that there were trials and short-term efficacy, but what we have learned from large prospective cohorts is that there are advantages that go well beyond, okay, I'm no longer able to walk, right? That was a big, we delay loss of ambulation, but now we know that there is great effect on delaying cardiomyopathy, delaying scoliosis surgery, and most importantly, quite important data to really push other milestones related to upper extremities function, which is hugely important for quality of life and community functioning, like hand to mouth and reaching above your head. So those are all milestones that also get pushed farther and farther in the life of patients who receive corticosteroids long term. So it goes well beyond loss of ambulation, which, in the very early days, 20 years ago, it was actually a practice that once you go in a wheelchair, we used to stop the steroids, at least some people do, and now we really have learned that there is a lot of other advantages, long-term advantages.
Did that answer your question?
Okay, I got a couple of questions from the online audience. First one is for Leanne. This question is, endocrine consortia recognized both the underlying DMD disease exacerbated by steroids as causes of the target issues, e.g. obesity and bone fragility. How are the steroid-naive groups factored into ongoing sensitivity, granularity, and vision?
Yeah, I mean, that's a really great question, and certainly in speaking with my patients, people are making a variety of different choices with respect to steroids, some choosing to come off if there are significant side effects, some choosing to stay on and tackle through anticipatory prevention of things getting worse. And so there's a whole myriad of ways in which the community is viewing the steroid landscape. So certainly what we're promoting is that whether you are an individual who is embarking on steroids or not, whether you're going to stay on steroids or not, that you need an engagement with an endocrinologist, osteologist, who can be on that journey with you. So we're not just interested in seeing the patients who are on steroids or staying on steroids, but we want to engage with patients no matter what their background so that we can deal with the weight gain issues and the bone fragility that is separate from glucocorticoid therapy. It's a great question. Thank you.
Hi, my son is 9, and we've been on Emflaza. This is going on the 3rd year, and in the past 18 months, he hasn't grown in height. So I got with a endocrinologist who, she's not a Duchenne's, certified, with a Duchenne certified group, but she's a very good endocrinologist locally that I use, and she wanted to put him on the human growth hormone, the nortotropin. And the endocrinologist we see, who is with the Duchenne certified center, she had mentioned that it was something we could try, but she wasn't really keen on the evidence that it would actually help with growth. So I'm like, let's do everything we can do to keep him, with his quality of life, so he can keep doing his daily activities that he's enjoying. I'm just wondering, what is the data on the nortotropin? Does it help with help with growth through the suppressed growth hormone, being on the long steroid?
No, it's a wonderful question. Thank you for that question. It's one that comes up in clinic very often because it is very hard to watch the boys as their growth decelerates, and I know that it's very distressing for the individuals with Duchenne and for their families. So the cause of the growth failure on steroids is that the steroids attack the growth plates of the bones. So we call it end organ failure, if you will. And so when you give hormones to try to wake up those growth plates, they don't work very well. And even when you give high doses of those growth hormones to try to wake up the growth plates are really quite sleepy. So it's been disappointing in terms of the mileage that we have gotten out of growth hormone therapy. If the patients were truly growth hormone deficient, that is, not making the growth plate in the pituitary in the brain, then that would be a different story. But the mechanism of the growth failure is really the steroids acting on the growth plate. There have been a few studies, not very many, and the results have been modest at best, with potential for side effects. And some of the side effects of growth hormone therapy are not insignificant, like impaired glucose metabolism, headaches due to an accumulation of fluid around the brain, worsening scoliosis. So when you have a situation where you have a therapy that doesn't really target the problem, doesn't make those growth plates wake up really significantly, and you have potential for side effects, then it becomes difficult to justify it. So we consider that growth hormone is not standard of care, and those of us who have tried it have not really been impressed by it enough to recommend it to families. Now, some families want to try anyway. They just want to, as you said, just sort of try everything. I want to make sure that there's not a stone that I didn't overturn, and I understand that. And so, I think in the hands of an expert who knows how to prescribe growth hormones safely with careful monitoring, then, if you really want to go down that road, that's a journey that I would be prepared to go on with a family. But just knowing that the benefit is likely to be minimal, modest, and then it's a daily injection. So you have to sort of weigh all the information there to make that decision.
So how about an additional question to that, changing the steroid regimen maybe to, maybe weekend steroids or...
Yeah. So that's another question that people have asked then. Can we protect the growth in the bones by adjusting the steroid therapy? And the evidence suggests that when you do that it comes at a cost to muscle. So you have to sort of decide, what is most important to me? Is it my growth? Is it preserving my muscle strength as far as possible? The moment you start to adjust those doses and take them intermittent, then it does tend to influence the muscle trajectory. But again, that's a very personal decision, right? And everybody will weigh that differently. And for some individuals and families, the growth may be prioritized. For others, it may be prioritizing the muscle health. And our job as clinicians is to make sure families have the information so they make an informed choice, and then to be on the journey with them regardless of the choice they make.
I just wanted to ask one other question in regards to that topic. So like I mentioned, we're like 3 years into diagnosis, and we've been on steroids 2 years. And like, if he remains on steroids and we take him off of the growth hormone, like, is he projected to grow in height anymore?
So if he remains on steroids, is he projected to grow? Yeah, so as long as the patient is on the sort of standard doses of steroids, then that would be expected to hold back the growth. Okay. Now, the bone age is very delayed because of the steroids affecting the growth plate, so the individuals who stay on steroids do grow longer, but ultimately the height is curtailed by the steroids even though they grow longer.
Okay. Thank you.
You're welcome.
Unfortunately, we're out of time. I'm so sorry. I'm sorry. Linda and Leanne and Emma are here all week, so feel free to ask them questions if you see them in the hall. They're more than happy to answer questions for you. Look for more subspecialty meetings in these areas as well as other areas this year, and we'll report back next year. Thank you so much to the panelists, and thanks for sharing your lunch with us.